Good evening, Dr. Pastanovich. This is Tyler Parker. I'm in your MFT8104 class for Psychopharmacology for Family Therapists. And this is my week 8 assignment where I'm going to go over common psychiatric conditions, etiology, symptomatology, and diagnostic criteria. And at the end of that, I'm going to do a make-believe case vignette, and I chose to talk about ADHD and treatment planning and the way that the patient is affected by the system and how the system affects the patient. Okay, so to start off, as requested, I have common psychiatric conditions that I'm going to be talking about. So first we're going to start with major depressive disorder, then bipolar axis 1 or type 1 disorder, attention deficit hyperactivity disorder, ADHD, substance use disorder, and I've chosen to focus on cannabis use disorder so I could get specifically the diagnostic criteria from the DSM as you requested. So to start, major depressive disorder, the symptomatology for all of these I've chosen to kind of lay out an assessment tool to help me as a clinician be able to decide the symptom severity, or to, I guess you could say, like clarify the symptom severity, or even confirm the presence of whatever mental disorder is being addressed. So in this case, I'm looking at Beck's Depression Inventory, or the BDI. That's a 21-question scale to determine condition severity. It's a pretty common assessment tool that's going to tell a clinician if someone has depression or not, because those tools are reliable. Each item is self-report from 0 to 3, so symptom severity ranges from normal to extreme. So this is something that the patient would be filling out themselves as they self-assess. Just something to keep in mind for the clinician is that when someone self-reports, you have to kind of, know that it's a subjective report, and there might be some discrepancies there, or it could depend on, if the person is having an exceptionally bad day. Maybe they are only thinking about all the horrible things that have happened, or whatever the case may be. So, etiology, there's no laboratory test that can determine if someone has major depressive disorder. It's something that you have to assess for, and it's something that the person will, say, well, yeah, this does apply to me. So there's no blood work or anything that you can do, unfortunately. Another part of etiology is it's supposed, at least the DSM says, that the hypothalamic pituitary adrenal axis hyperactivity is an investigated cause. So they're looking at the neural networks that are involved in causing major depressive disorder. Gene variants in neurotrophic factors and pro-inflammatory cytokines. So that's another way that scientists are looking to see what kind of biological correlates there are with major depressive disorder, and that's sort of just where the research is going right now. But like I said, there's no real blood test that you could take right now to determine if you have it or not. fMRI points to emotion processing, reward seeking, and emotion regulation networks. So they're just looking at activation on the cerebral cortex, or wherever it is that they're looking to determine, or further down beneath in the brain, what areas are active during major depressive episodes. So the diagnostic criteria, 5 or more of the diagnostic criteria must be present for at least 2 weeks, and at least one symptom must be loss of interest or pleasure or depressed mood. So it has to be stated that there are, periods of bereavement, or you could have a major depressive episode, which is also kind of part and parcel with bipolar disorder, type 1. So it needs to be assessed to see if it's just an episode that's happening to somebody, or if it's, over an extended period of time and it actually would be a disorder. So the diagnostic criteria, I went ahead and looked in the DSM and broke down what each of the clinical criteria were, just in general, without going into the different specifiers and things like that. But depressed mood for most of the day, that's going to be a self-report. Or in a family system, someone might be able to say, yeah, my husband or wife or child is in a depressed mood most of the day. At least it might look that way. Loss of interest or pleasure in activities. Someone's going to know if they just don't like to do the things that they used to do anymore. Significant weight loss or gain, plus or minus 5% in 1 month. That's a great clinical marker, just because you'll be able to measure for that, and you'll have like quantitative data as opposed to all the qualitative measures. So it's something that you can actually point to and talk with the person's physician about. of course, if you have the appropriate paperwork to be able to share patient information. But it's something that is measurable, that is less subject to the subjective nature of self-reporting how someone's feeling. Insomnia or hypersomnia, so sleeping patterns are going to change. Psychomotor agitation or retardation, and it's specified that it's observed, not self-reported. So that's another way that the family system can be sort of recruited to help a clinician understand what's going on with the person. Fatigue, that's a big one. Feelings of worthlessness or inappropriate guilt. So if someone is feeling like they're no good for no reason, they could be doing great. That would just be one of their symptoms that would be in that symptom cluster for major depressive disorder. Diminished cognitive capacity. So I noticed that it said diminished. All of these measures and symptoms are looking for from the baseline of where someone is normally to where they are now. So if it's diminished, it means that it's less than it used to be. So that's really important, I think, when you're asking someone how they're doing. You're comparing to how they were before the onset of this illness. Recurrent thoughts of death. Administer the scale for suicide ideation, the SSI. That's another one of Dr. Aaron Beck's devices. They're really great. Where if a person is thinking about death a lot, you want to make sure that they're not suicidal and going to complete a suicide. And if they are, you at least want to have had some sort of objective measure where you could say, what the risks are of this person undertaking something like that. So if they're thinking about death a lot, then they might be depressed. Sounds pretty obvious, but it's a part of symptom constellation. Now, all of these, and this goes with all the rest of the disorders too, impairment in social, occupational, and or other important life areas. If it's a problem, then of course a person is going to, qualify for having a disorder. I guess if it's not a problem, if it's just like, oh, this is just my everyday, then what are you gonna do? If it helps a person like get through something like, the manic phases of bipolar disorder, that's why it says that it has to be interfering with the person's normal living. And also, just like I talked about earlier, it's not due to bereavement or a particular depressive episode. So, moving on to bipolar disorder. Symptomatology in this case, assess for condition presence with the Primary Care Mood Disorder Questionnaire, or Primary Care MDQP. There's different variants of the MDQ that'll help a person determine if someone has had basically manic episodes or not. I just chose the one that was for the primary care physicians, and I like that one because it has some additional places to put information that the MDQ by itself just didn't have. So it's used for parents to rate their children, which I think is great for family therapy because it gives the parents and the children a chance to sort of like look at each other with an objective measurement device, as opposed to constantly just living in that subjective magical world they've created for themselves. So this is a way to assess for a mental health disorder that the parents can be recruited in. And I'll talk a little bit more about other people being recruited for basically clinical reasons when I talk about ADHD. So it's a 13 symptom related questionnaire. You basically fill out, like how much does this relate to you? Is this, all the time or never, or whatever the case may be. Temporal relationship. So basically what I'm trying to illustrate there is that some of the questions are saying, like what's the period of time in which this, these different symptoms have occurred? Did they, one thing happen forever ago, or did it happen within a close period of time? And in what order do things happen? Symptom severity, like I said, it's on a range. Family history, this one I thought was really good, because especially if a parent comes in with their child and for whatever reason they maybe think that they have bipolar disorder, it has a high incidence of, I guess you would say, heredity. Like if your parents have it, then you're likely to have it, so on and so forth. So there's probably a very strong genetic component. So asking that family history question is really important for the clinician because it'll let them know, what's the likelihood of this person having bipolar disorder or not. And previous diagnosis for reporting parent. So if a parent has already gotten that diagnosis before, then it's maybe pretty likely that you're looking at bipolar disorder. It just makes it a little bit easier, and you can gather that data. So I chose the bipolar 1 disorder etiology as opposed to bipolar 2. So for bipolar 1, 18 years of onset is typical, but it does have a range like everything else. Can be diagnosed in children with special consideration, especially so when you're talking about the developmental age of the child. It could be that, a kid is like 14, 15 years old, but they're very um, far along developmentally, so then you would have to take that into consideration when you're looking at, what's going on and does this child qualify for this disorder. Can have midlife or late life onset, so even above 60 years old, which I thought was pretty fascinating. But what the DSM recommends to do is if there's later onset, assess for a medical condition first or substance use and withdrawal. I think that's really key because it kind of ties into the mind-body relationship, and it brings in the expertise of the medical community, because a lot of times, from what I've seen so far in the course, if you do have some sort of medical complications, sometimes that can have psychological consequences. And so it's important, especially when someone is older, and their body is not working as tip-top as it used to. It might be that they're having a symptomatology that looks like bipolar 1 disorder, but is actually, something else that maybe a physician would be best to take care of that. Family history increases likelihood of disorder inheritance. So just like I said, if a parent has it, a kid might have it. So you want to check for that. So the manic episode, this is just some of the criteria that are required. So a manic episode must have occurred. So if a person just has a lot of the depressive state, so like you might classify them as having major depressive disorder, once that person has that manic episode, then you would say, oh, well, it's probably bipolar disorder, which isn't all that great because it's not predictive, it's more reactive. And so that's why, looking for that, the etiology of the illness is so important, because, you want to be able to tell someone, hey, you might get cancer in the future before they actually have it, so that they can do something about it. But it's just not something we have right now. So abnormally elevated or irritable mood with great vitality for 1 week. So vitality was my own words. What the DSM was trying to illustrate was basically like the person has a lot of life to them. They're kind of just like, for an entire week. So 3 or more of the following symptoms: grandiosity, decreased need for sleep. So a person is just very much like, oh, I'm on top of the world, or I'm Jesus Christ incarnate, or whatever. Decreased need for sleep, so they really don't feel like they need to sleep anymore, or they don't really want to. Excessive talkativeness, racing thoughts, distractibility, increases of goal-directed activity. So some of these things, when a person has their first manic episode or has a manic episode at all, they might feel like, this is totally great, like this is awesome, I can get a lot done, like everything is really clicking together in my head, like this is beautiful. But what goes up must come down, I guess you could say. Psychomotor agitation, excessive engagement in potentially harmful activities or activities with painful consequences, like shopping sprees or driving really fast on the freeway or skydiving without a parachute. I saw a guy do that today, and he landed in a net. I thought that was pretty cool. But don't do that. So a hypomanic episode is just about the same, but it's for a shorter period of time. And I've read in other places too that it says that it's not as big of a boom as a manic episode, but the same symptom criteria are in place there. So the major depressive episode is the same as for major depressive disorder. Obviously, it's concurrent with these other symptoms as well, and that characterizes it as bipolar 1, also known as manic depression. It used to be called, of course, so that's why we have that depressive side, is because it's referring to that. Okay, attention deficit hyperactivity disorder, or ADHD. So for symptomatology, all those symptoms can be found on the ADHD rating scale 4. That is a assessment device. I love assessment devices that can tell a person if a child qualifies for actually having ADHD or not. And I like it because it's aligned to the DSM criteria, which is very important. It's not just, you know, a list of questions that a person's like, oh, what about this? What about that? No, it's aligned to the DSM, and what we've stated is the standard criteria for the disorder. So it has hyperactivity, impulsivity, and inattention subscales, because those are two very discrete things that happen in ADHD. And they can, you know, hyperactivity might be very severe and inattention might be very mild. So it all depends, you know, taken all together, what that symptomatology looks like for the child or the person or the adult that has ADHD or may potentially qualify for having ADHD. So there's a 4-point frequency reporting scale. This ranges from never, like this never happens to me, this does not apply to me, or frequently, like this is my everyday. So it's an opportunity for a person to self-reflect and self-assess to kind of see where they are, and it can really help. So there's also parent-teacher report forms, which are really great. Parents are able to look at their child and say, okay, you know, is this Johnny's standard behavior every day, or is this something that he doesn't have? Or even when they're reading questions, they can say, oh, like, is this a thing? Maybe we should look for this. I don't know. And teacher report forms are good too. But I do have to say, for teacher report forms, a lot of times a kid might look bored or disinterested in a class. That could be just because the class is boring and the teacher's not doing a great job with classroom management or creating effective lesson plans that engage students. So, you know, taking a teacher report for ADHD should be taken with a grain of salt. They're not trained clinicians, and, you know, knowing that, it's important to know that, you know, they might be biased, they might not like the kid, they could have a vendetta against them for a bad test. Who knows what the case may be? But you know, teacher reports are great, but they are not the end-all be-all. The end-all be-all should be the clinician's decision, you know, made jointly and with the parents and the children in mind, and with them as well. All right, so that's enough about that. ADHD etiology, it develops in childhood, usually when a kid is pretty young. So it has to have multiple contexts in which the disorder is present. So it can't just be at school, like, oh, little Johnny never does his work, and little Johnny's always throwing pencils at Sarah. But then when he's at home, he's a perfect little angel. Then he probably wouldn't qualify for ADHD because it's not present in multiple contexts. So it has to be present, you know, at school, when he's at home, when he's at grandma's house, when he's on the playground, when he's at church, whatever. It just has to be more than one place. It's easier to identify after 4 years of age for children, because kids who are younger than 4 years old are pretty hyperactive if you've ever been around kindergartners or preschoolers. So it's kind of hard to say, like, oh, you know, little Susie has ADHD when every kid is throwing blocks around the room. So what makes little Susie any different? ADHD etiology continued. So this one has a little bit more objectivity to it. So low birth weight is one of the, I guess, predictors of ADHD. Smoking during pregnancy, you know, you shouldn't do that anyways. You're going to have a number of different complications. ADHD is just potentially one of them. Genetic risk factors. So if your parents have it, then you're more likely to have it. Dietary reactions, so it could be whatever the child is eating. Like, some people have bad reactions when they eat gluten, you know, and they get really tired after that. So there's a number of things that someone needs to consider when they're looking at the child's behavior. It's a holistic way of looking at the child. So this etiology framework is really great. There's a lot that you can do with it. Adverse personal history, abuse, neglect, sexual assault, all those different things. If that's happened to a person, they, you know, might develop ADHD at some time. Neurotoxin exposure kind of goes without saying. You know, if you're around dangerous chemicals like lead and things like that, you're probably going to have a few problems. Infections, of course, depending on the type of infection and how severe the infection is, there can always be like bad consequences for that. And alcohol exposure in utero. I don't know why you would drink when you're pregnant. But, you know, they found out that if you do that, then your child might have ADHD as well as a number of other things. Okay, so diagnostic criteria for inattention, 5 or more symptoms below present for 6 months or longer. Inattention to details, if a person, doesn't notice things when they're shown, or, in order to do a job, they're always missing things. Difficulty sustaining attention, I guess that goes without saying. If you're inattentive, that's kind of the definition. Does not seem to listen when spoken to. That, probably looks like someone just spacing off, or, like they're nodding, but then you ask them, what did I just say? And they're like, I have no idea. So that's a normal people thing sometimes. So I think that's why there's five or more. You have to have that specific symptom cluster. Does not follow through on tasks like, hey, little Johnny, I need you to clean your room. And you come back 3 hours later, oh, your room's still not clean. That's weird. What have you been doing in here? I mean, that's a normal human people thing too. So there maybe I just have it, but I don't. So I don't know, but does not follow through on tasks in multiple contexts. You have to remember that. Difficulty organizing tasks, if you're really scatterbrained. Dislike tasks requiring sustained attention. Yeah, but like I said, that could also just be boredom, and that's something that you have to contend with. That's why, again, it has to be present in multiple contexts. Loses materials necessary for task completion, so absent-mindedness. And easily distracted, like if they see a squirrel and they just, oh my God, what was I doing? Squirrel. Oh, okay, and they can't stay on one thing for any sustained period of time. And also forgetful. So, the inattentiveness is something that I think that I don't want to say a lot of people have, but everyone has periodically. That's why it has to, be assessed from mild, moderate to severe, and also you have all these other diagnostic criteria and things like that, because you sincerely do not want to overdiagnose ADHD, which I think in the 90s happened a lot, and a lot of kids were put on Ritalin just because they were being normal kids. Okay, so hyperactivity, 5 more symptoms below present for 6 months or longer. Fidgeting, leaving seat, runs or climbs when inappropriate. So if little Johnny's working at Whataburger and he's climbing on, the fry cook all the time, or like on the, whatever machines they have back there, probably he might have ADHD. He might be pretty hyperactive, even as an adult. Unable to engage in quiet activities, on the go all the time, like always like, right? Talks excessively, blurts out, can't wait for his or her turn, interrupts or intrudes. So, if a person is doing this consistently and it's getting in the way of their living comfortably, or in a way that they actually will enjoy, or functionally, then that would qualify. So like I said earlier, symptom severity, you have to specify that, whether it's mild, moderate, or severe. Okay, substance use disorders, cannabis use disorders, the one that I chose to address. So the symptomatology can be basically assessed to see whether it's there, whether it's not there, using the QPIT. So it's the Cannabis Use Problems Identification Test, 16-question self-reporting scale. A lot of those questions have to do with the clinical criteria for the disorder itself, like is this getting in the way of your life? How often do you use marijuana? Things like that. So that's really important, again, to have that objective measure. Even though it is self-report, it's a scale that's known to be reliable. So CUD etiology obviously comes from smoking marijuana. So from ingesting cannabis in various forms, however that might be, it doesn't really matter. It develops over a period of time. So this is really important, because it doesn't mean like if you smoke cannabis one time, then you have a substance use disorder. No, it's something that develops over the course of time, which we'll talk about in just a second. So frequency and amount typically increases. So you might go from 1 joint to 5 joints to get the same feeling. So excessive use and delinquency are markers of substance use disorders. So if you're constantly, maybe every day, smoking, that's probably a problem. Also, if you're getting into trouble while you're doing it, or in order to get it, that is also a problem. Use continues despite problems and consequences. So, with money issues, or if it's exacerbating some pre-existing psychological condition or medical condition and you're still doing it, you're losing friends, you're losing family, your spouse is really upset about it. yeah, those are problems, and if you keep using it, then that's definitely a problem. CUD diagnostic criteria, so 2 or more of the following in a 12-month period. So these are, I think, kind of, they're hard to pin down without an objective like assessment scale, just because it's asking for 2 in a broad range of things. So exceeding intended use. If you are like, okay, I'm going to smoke, 1 ounce this weekend, and you end up smoking that ounce in one sitting, and then you call up your drug dealer and you're like, oh, I need more, that's probably a problem. Inability to cut down or control use. So if you're trying to stop smoking, but you're still doing it, probably means you have a substance use disorder. Large time investments in acquiring cannabis. Um, well, now that cannabis is starting to become more readily available, I think that they might need to maybe change that, because prior to that, in order to acquire cannabis, sometimes took a large amount of time investment. Like you have to call the person and wait around, and it's always a mission, and it's always this, this, that. So, they, in writing the DSM-5, they were probably very cognizant of that, but not cognizant of the fact that ease of access is changing. So with that out of the way, craving, if you want to do it all the time, or you're like, oh, I really need to smoke right now. No, no, well, that might be indicative of a problem. Failure to fulfill obligations. So if you have things that you need to do, but you don't do them, because you're high or you want to get high, then that would probably be considered a problem as well. Even though there are a multitude of songs that kind of say like, oh yeah, like I'm high and I don't care about doing anything. That's a problem. Like, do not glorify that. Okay. Social and interpersonal life are affected. Like I said, you're losing friends and family. Maybe your children are like, I don't know why my mom smokes weed all the time. Like, it's not good for us. She wastes all our money on it. Forsaking other activities for cannabis. So if someone's like, hey, do you want to go ice skating? You're like, nope, I'd rather just smoke weed. And it's like, okay, well, that's getting in the way of your social life and other pleasurable activities, because this is the only thing that really gives you pleasure. Use in hazardous situations. So I mean, that's pretty broad and open to interpretation, I guess. But I mean, if you're like smoking weed like in a courtroom before your child custody case, that would probably be hazardous. Maybe not hazardous to your health, but hazardous to your well-being, and your sanity and your ability to win your case. Continued use despite health hazards. So if you're having a hard time, like you can't breathe, you can't run like you used to, or if you're having some sort of like psychotic break every time you smoke, that would probably be considered a problem. Tolerance develops. Like I said, you need more than you used to. It probably means that you have something that you need to address. And withdrawal symptoms develop. So if you have not smoked in a little bit and you're feeling like you really need it because like your heart's beating fast, you're sweating, or whatever the case may be, that might be considered a substance use disorder. So for the case vignette, like I said, I've chosen to address ADHD. So, typical scenario: high school freshman, male, 14 years old, with poor academic performance. So he's the youngest of 3 children, working mother and father. This is something that, no child in particular, of course, but it's something that I see pretty often, I guess you could say, being a high school English teacher. A lot of kids, have those classic inattentive, hyperactive sort of, what look like symptoms, I guess you could say. And, it depends on the kinds of lessons that I create that also shows or helps them to engage during activities. If they need to sit on top of the desk during the activities, go ahead and sit on the desk, because if I tell you to sit down, then you're not just going to be inattentive for like 90 minutes and we won't get anything done. So yeah, typical situation: high school freshman, male, 14 years old. That's sort of who we're thinking about here. So effects on patient systems, family, school, and social. So family struggling with student success and behavior in school and at home. So, what usually happens in a typical scenario is, child has ADHD, and it's really hard for them to focus during class. So their grades are suffering because when we have tests or do activities or have to turn stuff in, it just usually doesn't happen. And the parents get pretty upset about that, and the kids feeling frustrated too because the parents are upset. So doesn't stay on task for long enough to get anything done, whether that be room cleaning, homework, conversation. Um, some people have a really short attention span. So one thing that I like to do is make sure that we don't spend too much time on one thing. And if we do, that we're moving along at a quick pace. Like, okay, let's talk about this for some short period of time so that we can go ahead and move on from here. Anytime that you have a discussion or anything that drags on for too long, the first students that you're going to lose are the ones that have ADHD, because they're usually the first ones to sort of like their eyes kind of wander, and you're like, oh, I know I got to move on because we've been talking about this for way too long. All right, friends are few, and those that are present are irritated. So that's also something that that you might see and you might hear is other students complaining about students that have ADHD because they're poor listeners, or they do a lot of things that irritate other people. There's a lot of, I guess you would call them social deficits, but you could just say that they're kind of like difficulties, I guess you would say, especially when it comes to turn taking or understanding other people or listening for long enough to learn something new. That all those things that are part of the patient system or the child system or the client system are affected. Teachers aren't happy because the work's not getting done and the grades are bad. Parents aren't happy because the grades are bad. Kids not happy because his friends or her friends are, falling by the wayside because they don't want to put up with them all the time. It's not good. So school could be affected, social life, and as well as the family. Okay, so system effects on the patient. So family, school, and social. So at least what situations that I've seen, usually they feel frustrated, sometimes maybe angry about their treatment, maybe by other teachers or their peers or their family. And so a lot of times, at least what I've seen, is they create distance between themselves and everyone else. You know, not saying I'm creating distance between other people because I have ADHD, but because they don't accept me or they're just wrong, is usually the line that I've heard. So frustrated with making and keeping friends. So those friendship networks sometimes are like not so great, for the reasons that we talked about earlier, and they all basically come down to symptomatology. Now it's not such a clear like correlate where it's like, oh, like the kid is fidgety, or oh, the kid won't listen for long enough. It's like, okay, Johnny won't listen for long enough, and therefore when Susie tells him about her day and wants to like blow off some steam on the school bus, Johnny's not present for her, and because he's not able to pay attention as much as Susie wants. So all of a sudden Susie doesn't want to talk to Johnny as much as she used to, so on and so forth. So because of that symptomatology, the interpersonal system experiences some difficulty, and there's some frustration there, and that can sometimes lead to anger about one's own position and condition. So treatment plan, as a clinician, I would administer the ADHD RS4. So to confirm the presence and severity of ADHD, because I think that's most important to delineate first and foremost, is to make sure that what you're looking at actually is ADHD, on an objective clinical report, rather than the parents just bringing the child in like, Johnny can't pay attention, he has ADHD. Okay, great. That's a great place to start. What we can do is fill out this form and do this questionnaire so that we can figure out what is the symptom severity, or maybe it might be something else. We don't know. So let's try and figure that out. Build rapport with the family. So especially if, in our case vignette here, little Johnny is creating distance between himself and his family members and his friends because they don't accept him, or they don't understand him, or he feels like he's not being paid attention to, or maybe everyone else is too slow for him and can't keep up with him. We definitely need to make sure that we have rapport with the family and support built in so that they feel like they can address those concerns, like, well, mom just mad at me because school's too easy and the teacher's stupid. Okay, cool, like, I totally understand that you feel that way. Mom, let's listen to what little Johnny has to say, because little Johnny says that he's feeling frustrated because da 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 da. And if little Johnny sees that and hears that and is paying attention, he'll be like, oh, like, this person is actually listening to what I'm saying and telling my mom how I feel. That's really important. And it's important too, to make sure that mom has her concerns addressed. Like, oh, well, little Johnny's not going to get into a good school in college if he doesn't, bring his grades up. Oh, okay, so it sounds like both sides are having some frustration here. So let's see what we can do with that. So that leads us to our next phase, which is discuss and envision goals. That has got to be a collaborative process between the parent and the child as well, because if it's not, then it's just going to be one person against the other, and they might sabotage those goals in spite of each other. So making sure that everyone in the family system is communicating about those goals and actually understanding and caring about those goals is extremely important. So target the behaviors and processes they want to change. Maybe little Johnny likes the fact that his teacher lets him sit on the table when he needs to. Okay, we don't really want to change that. Or maybe little Johnny is in a place where, if he sits on the table, he's going to get sent to the dean's office. And it's like, okay, well, in order for you to be successful, like, here's some things that maybe we need to do. So maybe we could talk to the teacher and get you one of those bouncy chairs so that you can sit at the bouncy chair as opposed to the table. Plus, I think that's pretty cool, So that would be something that we might be able to do as well. Figure out what specific processes are getting in the way and seeing what specific things can be done about that. Referral to pediatrician or psychiatrist, especially if little Johnny is in the moderate to severe for maybe hyperactivity range of clinical symptoms, then maybe he needs to have some sort of medication that can help him to control himself a little bit more so that he can work on those goals and really make progress towards those goals. So after that, medication management is really important. Make sure he's taking it. Make sure the nurse is on board. If he needs an IEP or a 504, make sure that is in order. Parent management training. That's it's a way for the family to help children manage their symptoms. Sort of like, hey, when you do this, like, this is what we're going to do together so that you can calm down. Or, and the kids are invested in the process too. It's just a strategic way for a family to sort of take on the roles of reining in the symptomatology that's getting in the way, so that they can make some positive changes. So instead of, it's like having a clinician in your pocket, right? Whenever you need them, you just pull them out and say, remember our strategies, here's what we're going to do, right? That's really important so that after the family leaves the office, they can sustain themselves and get better. So what I'm envisioning for a therapeutic course of action would be solution-focused family therapy with medication when the medication regimen is established, depending on ADHD severity. So I think that solution-focused therapy would be great here, especially because it's mostly, if not all, just based on reaching some goals, finding solutions. In this case, I think that when all of the other things have been put in place, you understand the symptom severity, you've got the medication in place, you've got the parent management training put in place, then you're free to just focus on those goals. Like, little Johnny, I want you to try and get a B in this class because you have an F right now. Like, let's try and reach that goal. I think that it doesn't have to be super introspective, but I think that the whole family needs to be involved in reaching and achieving those goals. So that's why parent management training is so important to incorporate in the family system so that they can do that on their own, but also never losing sight of those goals. And finding those solutions, I think, is really critical. So that's the treatment plan that I would have. And then, of course, you know, as therapy progresses, as the treatment progresses and goes across time, then you can start setting some, you know, goals about, okay, like when are we going to terminate therapy? Like Johnny has an A in this class now and he's doing great. He knows when to take his medicine and he knows how to self-soothe, you know, then you can start to think about treatment termination. So here are the references that I used. Obviously the DSM-5, the QPIT, Beck's Depression Inventory, Scale for Suicide Ideation. I also used the Screening for Bipolar Disorder and Primary Care Practice Assessment Tool, and also the ADHD Rating Scale 4. So I hope that that was sufficient. And I also hope that this was recording the whole time. Oh my God, if it wasn't, I'm gonna have a heart attack, but I'm pretty sure it was. Okay, excellent. All right, so thank you very much, and if I need to include anything else, please let me know.